Hi everyone, this is Laura Pegram from NASDAQ. I am just here to do a little brief housekeeping. I do want to start to share my screen in just a second, and so you should see the beginning of our presentation here for Hep3AZ. Exciting day, supported by a really exciting panel. So again, NASDAQ is helping to host this webinar, so really I'm just kind of here for logistics and a little bit of talking later. But any questions or comments, folks can put into the question box, right, which is on the icon on the left, right, that you should see there. Feel free to send those throughout the presentation, and if they're directly related to a question or a speaker in the moment, then we'll try to answer them as they come in. If not, we'll probably wait until the end for more of the discussion and question and answer section of our presentation. So for now, I'm going to go ahead and turn it over to Chris Abert.
Hello, everybody, and I wanted to take a minute to welcome you all to the first in a series of webinars about hepatitis C elimination in Arizona. And today's presentation is going to primarily aim at providing a glimpse into hepatitis C elimination planning that's being done across the country, as well as give audience members a chance to ask our distinguished panelists questions. So as we move forward, we have them at our disposal to help us. We'll begin with a short presentation by each of the panelists, and then at the end, as Laura said, we'll do open questions and answer format. So feel free to, as we go through, put any questions you might have into the chat box. Just real quickly, a bit about the Southwest Recovery Alliance. We're a peer-led nonprofit. We're working in Arizona to build power among and share resources with people who use drugs. Our ultimate goal is that people who use drugs be able to make self-directed positive changes in their lives. And unfortunately, there's a lot of crushing stigma, criminalization, and discrimination that stands in the way of our goal. This leaves people who use drugs particularly vulnerable and alone. So we know that people who use drugs aren't the only people impacted by hepatitis C. However, we are going to need to engage that community if we hope to stop transmission and have elimination. So that's where hopefully we can help. We really want to be a bridge to build community and to join together various communities so that we can all work together and change policies that are standing in our way. Today's webinar is not a deliverable. It is not a requirement. In fact, most of the funding that we get from our small grassroots organization comes from our volunteers and from our participants. And our volunteers usually are our participants. Our board of directors are participants. So it really is nothing about us without us. We think that if people are going to make it out of situations where they are oppressed and not able to access services, they need to lead the way. So this is a labor of love, I guess is what I'm saying. And oftentimes it's a labor that is the difference between life or death for people. So thank you for joining us today. In the interest of time, we'll just get started. We're thrilled to have Arliss Jenkins. She is the viral hepatitis coordinator with ADHS, and is gonna start us off with a snapshot of hepatitis C in Arizona and some of the opportunities that are available through ADHS. Arliss?
Yes, thank you so much, Chris, for the introduction. Good afternoon and welcome. Thank you all for joining in today's webinar. As aforementioned, my name is Arliss Jenkins. I'm the Viral Hepatitis Coordinator at Arizona Department of Health Services, and it is my pleasure to share with you this afternoon a little background on hepatitis C and specifically the burden of hepatitis C in the state of Arizona, which is in part where much of the motivation and impetus for hepatitis C elimination is made clear. So just to make sure we're on the same page, as everybody knows, hepatitis C is a blood-borne virus that attacks the liver. After exposure, the infection starts off as acute. Some are able to naturally clear the infection. However, the majority will go on to develop a chronic infection, which may later lead to fibrosis, cirrhosis, and ultimately liver cancer or liver failure. In 2014, direct-acting antiviral treatments became available with 95% and greater cure rates, and yet hepatitis C remains a major public health issue worldwide, nationwide, and Arizona being no exception. So I'll go ahead and get into some data for you guys. From 2013 to 2017, the number of electronic laboratory reports increased by 37.4%, so more than a third. Reports went from 5,333 in 2013 to 7,329 in 2017. And this is an upward trend that we see continue on through 2018 and 2019 as well. In Arizona, hepatitis C is one of the most commonly reported infectious diseases, with only chlamydia, gonorrhea, influenza, and now COVID-19, of course, seeing higher numbers of reports. And this is of particular interest when we consider that comprehensive surveillance has not been conducted in Arizona since 2008. So Arizona is a home rule state. That means that local jurisdictions conduct case investigation work, but they're often understaffed and under-resourced and not able to do that for hepatitis C. So therefore, we use electronic laboratory reports as a proxy to estimate the burden and to indicate trends. But this is not completely representative. For example, race and ethnicity information is often incomplete. We see about 10% come through with that. We also often do not see payer or risk factor information as well. That's typically unavailable. What we can determine from electronic laboratory reports is that in 2017, 59.8% of reports were among males. By age group, the majority of reports are among baby boomers, as you guys can see on that chart there. So that's aged 55 and older. However, there have been an increased number of reports among those aged 18 to 30 years of age. In terms of people living with HIV, we see about 8% of those individuals co-infected with hepatitis C. And in terms of geographic reach, we see a majority of reports in Maricopa County and the more populous counties. However, some of the more rural areas in the state have the higher rates, such as Mojave County, as you can see on that tiny map there in the top left, the northwestern corner. Mojave County had the highest rate from 2002 to 2008, back when we had comprehensive surveillance, and that has continued on until now, where we use our electronic laboratory reports and still see Mojave County have the highest rate. So we talked a little bit about the numbers, but I'd like to take a moment to share with you some of the qualitative data as well. Last February and March, ADHS conducted 3 hepatitis C listening sessions involving over 24 agencies and 50 participants. If you were one of those participants, thank you very much for your involvement. When we asked about current attitudes surrounding hepatitis C in our communities, one of the first things we heard was, people just don't care. They view Hep C as a problem that will happen down the line. It is a silent epidemic, and there is a general level of apathy. Another shared that there has been a pivot from traditional venues to non-traditional venues, and a lot of people are fatigued by the process. Stigma is real. So there is clearly a lot of work to be done, work that is beyond the capacity of any one agency or group of people. At ADHS, we are working internally to collaborate with our HIV team and our STD teams and to strengthen our data surveillance system for hepatitis C. But what we are most excited about is to put that data to action and to prioritize people living in Arizona who are at increased risk and / are living with hepatitis C, in addition to family and friends that are also impacted. So therefore, we are very excited to announce that we are partnering with Southwest Recovery Alliance and the American Liver Foundation's Arizona chapter to form a statewide hepatitis C elimination advisory group. And this is happening as we speak. The first meeting will convene this fall virtually. So as you listen to the rest of the presentations this afternoon, I encourage you to consider participating. We will make that information available at the end of the webinar. My information is on the slide too, very tiny, but feel free to reach out to me and I can send out applications, or if you're interested in any other form of collaboration, we are certainly interested in speaking with you further. And with that, I'd like to thank you for your time, and I'll turn it back over to Chris.
All right, thank you so much, Arliss. I appreciate all the information and all the work you put into helping get the Elimination Advisory Council going. It's very exciting that we're going to start working towards elimination in Arizona. Next up, we have Michael Nimberg. He's the Executive Director of the Hepatitis Education Project and a long-time hepatitis C advocate. Today, he's going to share a little bit about the national landscape of HCV elimination. Michael.
Great, thank you, Chris. And I am going to give an overview of elimination efforts and how they came to be, and also Very importantly, talking about what Chris mentioned earlier, hepatitis C doesn't just affect people who use drugs, but that is where the overwhelming majority of certainly new cases are now, 3/4 at least in the US. And interestingly, most new cases of hepatitis B as well in the last several years have been attributable to injection drug use. So yes, thank you. Next slide, please. So the idea of hepatitis elimination goes back a ways. Hepatitis A and B are vaccine preventable, so very easily a condition that can be eliminated if people get vaccinated. Hepatitis C treatment has been around almost as long as hepatitis C has been diagnosable. I was a hepatitis C patient. I got hepatitis C from injecting drugs. I was diagnosed in 1990 when almost nothing was known about it. It had just been cloned and named the year before. And when I was told I had hepatitis C and asked, what does that mean? I was told, don't worry about it. You've got more important things to worry about, which in the context where I was told that at a drug treatment center, that was actually, not inaccurate. Because hepatitis C is so slowly progressing in most people. I was eventually treated and cured in a clinical trial about 10 years ago, but lived with hepatitis C for 20 years. And like Arla said, for most of that time, it was just something that, was down the road and I didn't really think about until I was also diagnosed with cirrhosis. So elimination really kind of got a global kind of stamp of approval through the World Health Organization in 2016 when the 194 member states ratified targets for the elimination of viral hepatitis as a public health threat by 2030. And since then, a number of states, cities, counties, other clinical kind of healthcare systems have come up with their own plans to eliminate hepatitis C mostly, but more now we're seeing a combination of the elimination of viral hepatitis, and we'll talk about that in a minute. And I will say this is from HHS, and it does have a list of the organizations or agencies that have worked on these plans. If you click on Arizona, it is the Southwest Recovery Alliance. So kudos again for getting that going. Next slide, please. So I wanted to let everyone know that there's a great tool that looks at treatment access for hepatitis C in the Medicaid setting at the state level. And again, treating people who inject drugs is really, for my money, which is not much, the place to start elimination efforts. I would say people who inject and people who are incarcerated because of the very high prevalence and the public health impact of stopping onward transmission if someone is continuing to inject drugs. And so in state Medicaids, there are primarily 3 kinds of restrictions that have been put in place to really prevent people from getting treated and cured from hepatitis C. And it's really as a cost containment mechanism, although since prices have dropped about 70% in the last 4 years, that argument, which never really did hold water, is certainly not an argument still. So the 3 areas of restrictions, and you can see Arizona has a C+, so up from where it was. Next slide, please. So the 3 restrictions are generally the degree of liver damage a person has. So many states have a criterion in place that a person has to have a certain degree of liver damage to even be eligible for treatment. So basically they're saying you have to progress to a certain degree of sickness before we'll even consider treating you, which is unlike any other disease state that I know of, certainly. The most, I would say, relevant to the work that we do in harm reduction is the sobriety restriction. And many states still require someone to be sober or abstinent for anywhere up to 6 months before they can even be treated for hepatitis C. And then many states, the most common restriction is who can prescribe the drugs. Many states say that it has to be a specialist, a hepatologist, sometimes an infectious disease doctor, or sometimes it has to be a primary care, or it can be a primary care clinician in consultation with one of the specialists. So you can see we've got the recommendations here, and I will say that this State of Hep C tool, and that's the URL, stateofhepc.org, is collaboration between the National Viral Hepatitis Roundtable and a group out of Harvard Law that does health law policy. And so click on each state, you'll have your report card and then the recommendations. And I'll show you briefly now, next slide, what we've been able to do in the last 6 years since these first restrictions went into place. And these, there were no restrictions for hepatitis C treatment up until 2014. Treatment was expensive, before these new therapies were approved in 2013. The last iteration was somewhere between $70,000 and $80,000. But because so many people were waiting for treatment, there was a wave of people that was smaller than anticipated that made Medicaid directors fear that they were going to go bankrupt treating their hepatitis C patients. And so that's when they started putting up these barriers. And so you can see the fibrosis restrictions, which were in a majority of states in 2014, are only in 5 now, which is a huge win on the advocacy level. And this really is a result of advocacy at the state level. Next slide, please. We've also had some very good success in sobriety restrictions, but nowhere near what we need. In Washington State, for example, we were able to work with our state Medicaid over the course of several 6 to 8 months to slowly whittle away at their sobriety restrictions. It was 6 months, and then it was 3 months, and in consultation with a counselor. And then what we finally were able to get them to agree to was, in addition to all of that, there was a psychosocial readiness component that the clinician had to kind of sign off on. And we made the true argument that if a client or a patient is psychosocially ready, whether or not they're injecting heroin every day, then they can get treated for hepatitis C and be cured. And we have the data to show that people who use drugs are treated equally effectively as people who are not using drugs, as long as they are adherent. Next slide, please. And then the prescriber restrictions are probably the ones that are most prevalent still, but we've also made some progress there. And so if you do have any questions about advocacy at the state level, happy to answer those questions during the Q&A. NVHR, the National Viral Hepatitis Roundtable, is another organization that does great work and is part of HEP, and we're happy to connect you with advocates around the country. Next slide, please. And I'll just finish with the first elimination plan for hepatitis C at the state level in the US was in Washington. So I have to kind of give a shout out to the team here. Emily Hirio at our State Department of Health did a fabulous job pulling together a really kind of broad array of stakeholders. Next slide, please. And to Arlis's point earlier about making this participatory, it really has to be something that involves everyone who's connected to the epidemic. So on the right-hand side, you'll see the 3 in kind of the aqua are more around harm reduction, but this goes to any number of different domains. And I would say, again, I just put an emphasis on the correctional health piece, because of the Americans living with hepatitis C in any given year, somewhere around 25% are either incarcerated or in some form of correctional custody. So again, that's a ground zero place for addressing hepatitis C in the US. And then last slide, next, I do want to give a shout out to our colleagues in Hawaii because they just released this plan, and incredibly thoughtful, very intentional, and they took a broad viral hepatitis approach. So whereas our plan in Washington State is specific to hepatitis C, and there are political reasons for that, the governor wouldn't sign off on anything that was more complicated than test, treat, cure. In Hawaii, they really had buy-in from their state government, the lieutenant governor, and they have a plan now to eliminate hepatitis A, B, and C, and they did it incredibly thoughtfully. They're more than happy to share all of that information, and I can get you that information for their plan as well. Thank you.
Thanks, Michael. Appreciate all that information. Next, I'd like to introduce Laura Peaker, who introduced at the very beginning with the housekeeping. She's the Associate Director of Drug User Health from NASDAT, and she's going to touch on the intersection of addressing drug user health and hepatitis C and HIV elimination, as well as a couple of other topics. Welcome, Laura. Thanks.
Have to unmute myself. So thanks, Chris, and thanks everyone for being here. I feel honored to be on a panel of such well put together people, really doing vitally important work. So yeah, like Chris said, so I work in an organization called NASDAT, and I'm the Associate Director of Drug User Health. So NASDAT is a sort of wonky acronym, and I put up our slide here to mainly just reference sort of our vision and mission statement. NASDAT, stands for the National Alliance of State and Territorial AIDS Directors. There's lots of reasons we don't use that, use the sort of spelled out version anymore, because we work also with viral hepatitis programs. We work increasingly with drug user health programs at the state health department level. So we have been an organization since 1992 and really work at sort of the intersection of these sort of syndemic issues, right? And increasingly over the last probably 10 years or so, NASDAT has really focused a lot of increasing effort on supporting drug user health programs and syringe access programs across the country very explicitly. If we want to get to that vision, right, the vision statement here of, a world free of HIV and viral hepatitis, there's absolutely no way that we can do that without focusing on preventing HIV and viral hepatitis among people who use drugs. Increasingly, as Arliss mentioned, in Arizona numbers, but across the country, about 10% of new HIV cases are related to injection drug use, and close to 70% across the country of new HCV cases are related to injection drug use. And increasingly, we're seeing that on a younger and younger group of people who are getting exposed to in particular. And so, there's no way that we could do this work and have a vision like this without really focusing on how to support syringe access all across the country, thinking both programmatically and in terms of policy. And so, we do a whole range of things, related to providing technical assistance for programs that are new and starting up, and helping to work with health departments to help figure out how to support drug user health more broadly within their jurisdictions. And so always really, really grateful to be doing that work. Like I said, syringe access programs are the most evidence-based intervention for preventing infectious disease related to injection drug use. Just hands down, that's for real, right? And as was mentioned, there's certainly restrictive policy environments and a range of policy environments, like Michael said, across the country for reasons that sometimes these programs can't operate or operate in a restricted environment. However, that doesn't change the evidence and sort of getting on board with that evidence. And recognizing those new numbers, numbers increasing incidence among younger folks who are using injection drugs, we need to be targeting our resources to a space where we are reaching those people, right? Reaching people who are using drugs across the country. So it just feels like a really common sense place to think about co-locating services and really making central what services are available for the people who are already really good at working with people who use drugs. I don't know, super common sense. Like, let's find the people who are good at working with people who use drugs. And as Chris mentioned, those often people who use drugs who are starting some of these programs who are the best at reaching this group, right? And so, really building upon, the strengths of these programs across the country and making sure that they're operating in alignment with what we know is evidence and what we know is best practices in terms of program implementation. As we think about linkage to care related to HCV, testing for HIV, HCV, all of that, I think we also need to really, we're in a moment where syringe access programs are really reaching people, people who are experiencing multiple intersecting issues, related to health and COVID. We can't have this conversation without mentioning sort of, the elephant in the room. Then COVID is one of them, and this is another space that I think we really are seeing a push at both the federal level and at many jurisdictions to really be focusing on building supports and services that are available through these programs, because, like I said, these are the people who know how to reach people. And so really centralizing and re-centralizing the array of services that could be offered through these incredibly effective programs across the country feels like a really vitally important thing for us to be thinking about, and doing what we can at the state and jurisdictional level to make sure that feels possible and can happen. I think there's also the idea of, like, when I think about these programs and the way I started to think about them, so, the reasons why they are so good at reaching people, is you're looking at this highly marginalized group of folks, people who experience such shame and stigma and marginalization and criminalization related to their drug use that they're pushed away from mainstream medical services. And at the end of the day, harm reduction services and syringe access programs are sort of just an alternative system of grassroots medical care and services. And the more that we can be positioning these folks as being as essential and frontline and just really central to any kind of elimination effort, especially for hepatitis C, the better. And, like I said at the beginning, there's actually no way that we're going to get around that. Michael stressed corrections and prisons, and I agree. We're going to have to focus testing and resources, treatment and access to care in prisons. We're going to have to focus, in these resources towards syringe access programs and drug user health programs across the country as well. So I think, my message and sort of take home for states, and folks on this call is really just like, let's make sure that we have a broad enough net that we're casting, and that we're putting resources onto the really vital pillars of who at the end of the day is going to be creating these services, and who are really the experts at working with people who use drugs in these jurisdictions. It's just really vitally important, and making sure that our money is where our mouth is in terms of we're committing to do this, and so, like, let's make sure that we do it right, and make sure that those programs have adequate resources and increased attention and support. So I didn't make a whole lot of slides. I actually felt kind of peer pressured by the other slides, so this is the only one I have. But I'm glad to answer questions about any of that moving forward, and I'm glad to pass it along. Back over to Chris.
Thanks, Laura. I appreciate it.
Yeah.
Now we're going to move to Dr. Carla Thornton. She is the Associate Director of Project ECHO and a professor in the Division of Infectious Disease at the University of New Mexico Medical School. I can pretty safely say that she is among the foremost experts in hepatitis C and in treatment. And so she's going to talk a little bit about treatment with ECHO as a tool for elimination, and treatment in general as a tool for elimination. And I'm hoping maybe she can give a definitive answer about whether a specialist requirement is needed in today's climate of hepatitis C cures. Dr. Thornton?
Great. Thank you, Chris. Are you asking me that question first, or you want me to go through my slides first?
However you want. I just couldn't wait for the question and answers
section.
Section.
Awesome. I'll definitely address that. So thank you so much for inviting me. I'm really honored to be here. And like Chris said, I'm just going to talk a little bit about the ECHO model for those of you who don't know what it is, and then talk about it as a tool in your toolbox for hepatitis C elimination. So, and I'm the guilty one of having a bunch of slides, but I think the images are helpful for me. So Project ECHO stands for Extension for Community Health Outcomes, and our motto really is moving knowledge instead of people, and that'll be clear in just a minute. Next slide. So Project ECHO really started around the problem of access to care for hepatitis C. And in 2004, my colleague Sanjeev Arora was really the only person treating hepatitis C in the entire state of New Mexico. And there's not that many people here, as many of you know, there's only 2.2 million people, but it's a huge state. And people are spread out very, very far, the low population density and very few healthcare providers in a lot of counties. So he, at the time, knew that we had 35,000 people reported to our Department of Health. And as Arlie said, the surveillance is not great anywhere, especially in New Mexico as well. But we knew about 35,000 patients, very few of them had ever been treated. And we currently have over 65,000 people reported to our Department of Health who are infected. So he was trying to figure out, how can I possibly get this, get treatment, make treatment more available in places that aren't the center in Albuquerque. So next slide, please. So the goal at the time was to safely and increase capacity to safely treat hepatitis C in all areas of New Mexico. Next slide. The ECHO model is very simple. It's we use technology to leverage scarce healthcare resources, and the technology, the resources that we needed at that time were really the expertise and knowledge to treat hepatitis C, because there wasn't much of it in the state. So that's the resource we were trying to leverage. We use case-based learning, which is really the heart of the model. And Sanjeev always talks about how he learned how to be a hepatologist and a specialist was to see a patient, present to his mentor, go back, see another patient, present to his mentor, and over time he would learn himself to be an expert. And so he thought, I've got to figure out a way to do this with all of these primary care providers all over New Mexico, whoever's willing. And at the time we were using interferon, as you all know, so it was really difficult, and nobody in primary care was treating hepatitis C at the time. We share best practices, and then we monitor outcomes. Next slide. So the steps that we go through, we actually bring, we used to bring people to us to be trained for hepatitis C, and we are doing that virtually now. So once a month for about a 3-hour training, we invite teams to come learn about hepatitis C, learn about ECHO, learn about treatment, and then they start participating in what's called a knowledge network or a tele-ECHO clinic. Next slide. So this is a picture of a tele-ECHO clinic or session, and this is a hub and spoke model. So the hub is here at the university, is myself, Paulina Deming, who's a pharmacist, Sanjeev is to my left, and there's a psychiatrist as well at our hub. And the spokes are on the other end on the screen, as you can see. We use the Zoom platform. They all come on individually from their sites, their clinics, or wherever they're located. And if they want to present a patient, they fill out a form, very simple, with the essential information, and then we discuss that case and give them our feedback, but also get feedback and information from the rest of the network. Next slide. And I don't even think Sanjeeva thought about this when he created this model, but what we call it now is a learning loop. So this is not a unidirectional, a specialist saying, do this, do that, this is the way to do it. It's really a multi-directional learning. We co-manage cases with people, but they also learn a lot from their peers. They learn by doing. They learn by brief lectures that we have during our tele-ECHO sessions, about 8 to 10 minutes usually, in a 2-hour session. And they have a resource that they can go to every week if they want to come and just learn and not present patients. Our tele-ECHO clinic has been going on for about 15 years, the exact same time every week from 3 to 5 on Wednesdays. So we have a community of practice here in New Mexico that's been long-standing. And this learning loop is really important for collaborative problem solving. Next slide. So just if you haven't gotten that yet, this is nothing like traditional telemedicine. Traditional telemedicine is a one-to-one doctor to patient relationship. This is a capacity building model where we train a group of people to treat so that we can increase the capacity. Next slide. So this is just a snapshot of our tele-ECHO clinic right now. We have a lot, the black dot is us at the university, the hub, and the others are spokes. We have a lot of different types of people who join us, mostly community health centers, mostly FQHCs, but there are other sites as well. And we're working with some of our harm reduction sites, as people are mentioning. The very, very important thing that we need to do is to get treatment into harm reduction sites and syringe services sites in New Mexico. Next slide. So in 2004, we were treating about 100 patients a year, and you can go ahead and click it again. And this is data from 2017, but we treated more patients in our own clinic. But the dark blue bar shows the patients that were presented to ECHO during that year. And then the lighter blue is really the people that they treated that weren't presented to us. So when someone joins the tele-echo session, they become experts themselves. So over time, they really don't need to present many of their patients at all, just the ones that they have problems or questions about. Next slide. We also run a similar program in our state corrections department. We have 11 prisons that are spread all over the state, about 7,000 prisoners and inmates in the state system. And we've been checking antibody upon entry into the prison for over 10 years, and it's 45 to 50% every year. It's the same. And about 75% of those are viremic. So we have a huge hepatitis C problem in our corrections department. Next slide. We also started a peer education program about 10 years ago using the ECHO model as well, where we train inmates about, it was really started around hepatitis C because there was so much in our prison. We train a lot on transmission of the virus, on prevention, treatment, we train on addiction, and then we connect with them virtually every 2 weeks to do, the cases that they present are really issues within their setting that they're trying to solve, and they need help with their other peers and also from us. So it's a very interesting program that I think is really going to help in our prison system to decrease the hepatitis C transmission. Next slide. And then lastly, we also run an Indian country Hep C tele-echo program that started out in New Mexico and really on Navajo, but it's gone, there are now 4 different hubs around the country run out of Portland, and then the one in New Mexico. And we connect with people all over the country, but really the focus in the initial Indian country echo was in New Mexico and Arizona. And we connect with tribal and IHS sites to treat hepatitis, to mentor people to treat Hep C. And the majority of the people treating in these sites are actually pharmacist clinicians. It's a really great program where the pharmacist clinicians are really taking up treatment in that setting. Next slide. So lastly, I wanted to mention too that we have, there's an echo, a Hep C echo in Arizona run by Dr. Richard Manch and Ann Moore, and they're on this webinar. I just found out, so I'm very excited about that. And they will put their information into the chat. So if you are interested in joining Hepatitis C Echo, they're amazing experts in hepatitis C. So how can this be used for elimination? Hep C treatments like the one we mentioned that we have the most experience with, we've been doing it a long time. It's a way to increase capacity to treatment. We've shown using the ECHO model that primary care providers can treat hepatitis C as safely and effectively as a specialist. And there is absolutely no reason that a specialist has to treat hepatitis C. They need to learn and they need some mentorship sometimes, but it should not be a requirement. We've been doing it for a very long time, and it's not necessary that a specialist do this. We also think that the ECHO model can be used. The ECHO model can be used in prevention around hepatitis C elimination. So the peer education is an example of that. There's also substance use disorder tele-echo clinics. There's about 80 of them around the country. So again, a way to really increase capacity for substance use disorder treatment. And then where I think there's a huge opportunity is in harm reduction and syringe services programs to do ECHO programs. Our Department of Health started ECHO in their harm reduction program in early 2020 that we're very excited about, where they're connecting with all of their sites to try and just improve practice and answer questions and work together to solve this problem. And then I think there are other ways you could potentially use this model. And one way that I think would be very exciting would be coordinating the actual statewide hepatitis C elimination response and working together in a collaborative way like that. So I know that was a lot of information, but that's my last slide, and I'm happy to answer any questions during the question and answer portion.
Thank you, Dr. Thornton. I appreciate it. We have quite a few echoes here in Arizona, one of which is about medication-assisted therapy, and there is a harm reduction aspect to that. So if people are interested in that, put up information in the chat box. Okay, and then finally, the last part of this portion of the webinar will be Katie Burke, She is the viral hepatitis coordinator at the San Francisco Department of Public Health, and she's going to discuss the importance of community leadership and involvement in HCV elimination, as well as some prevention efforts. Katie?
Hi, thanks, Chris. Sorry to be late with turning my camera on. I'm using a weird computer. But I'm going to talk a little bit about our work at both so I'm the viral hepatitis coordinator at the San Francisco Department of Public Health. Like Chris mentioned, I also helped to co-found HEP-CSF, which is our city-based Hep C Elimination Initiative. I think we're the first US city to create an elimination initiative. And we do use a collective impact model that Michael referenced. So we're bringing in lots of partners together. So I wanted to just get a little bit concrete about what community leadership looks like for us and some of our strategies for that, and talk a little bit about our relationships with our local harm reduction programs. So next slide. So we have been kind of very strategic, and we're fortunate in San Francisco. We have a kind of highly developed drug user health infrastructure. And so we've been really intentional about partnering with our syringe access services, with our overdose prevention services, with all the places that folks are trying to access buprenorphine, PrEP, to really think about methadone, to really think about like how can we integrate hepatitis C testing and treatment interventions into these settings where our target population already like are going and already have relationships. And I can be more specific if you guys have questions in the question and answer period, but just wanted to kind of put that out there, that is sort of our starting point for all of the programming that we've developed, is sort of where are folks already going, and how do we partner with them to bring Hep C treatment to them. So instead of kind of putting it over here where, you know, like maybe people will show up, it's like, where are they already? Next slide, please. And just a word too about sort of our efforts at community and participant leadership, is one of the things that was really important for us was to develop, you know, not just a vision and mission, which you can read here, I won't read it out loud, but also some values. So if you could just press down again. There you go. Yeah. So we have, we talked not just about kind of wanting to eliminate hepatitis C, but how we wanted to eliminate hepatitis C from the very beginning. So HEP-CSF launched in 2016. We kind of immediately had a strategic planning process. And as part of that planning process, we got really into like, okay, we want to be really explicit about everyone deserves access to a cure, that we need to draw on the wisdom of communities most impacted by hepatitis C. We need to really engage on populations that have been characterized as difficult to engage because they need the more help, and so the most help, and so our programs have to really address that. And I think that this kind of value kind of defining process was really crucial for our initiative and has been a really important kind of roadmap for us as we've grown, as we've developed new programs. Next slide, please. So we also kind of thought a lot about community participation, and so, you know, we keep all of our kind of work group meetings open. Everyone's welcome to come to work groups. We have a coordinating committee. We're very intentional about making sure that we have representation of, you know, doctors, of epidemiologists, of people that have lived with hepatitis C, of folks that are, you know, kind of drug user health activists that are open about their own history of substance use or current substance use, you know, folks that work in homelessness, that have experienced homelessness. So those people are all a part of our leadership committee and participate in our regular kind of coordinating committee meetings. And we also know that we need to have lower threshold ways of inviting folks to participate. And so one of the interventions that we made for that, just because we know not everyone wants to like go to the health department for a meeting, that's not always the most like relevant activity for folks. So we started to create these community meeting structure, and this is something that we really need to rethink. A lot of what we've done is requiring a lot of thought in the COVID-19 era. We can't bring huge groups of people together for community meetings now, unfortunately, and it's been a challenge because the sort of technology access in our target population is certainly uneven, and so doing Zoom meetings and stuff isn't as helpful and fun. But just to share a little bit about what these meetings did look like pre-COVID, so we'd always have a really nice dinner. We'd have like a raffle, we'd give out prizes. We always had a photo booth with like sayings and a giant liver that people would pose with. We'd do like brainstorming sessions. We'd always have an Ask the Doctor, Tell the Doctor session where a doctor can kind of talk about a topic related to Hep C, and folks can ask any questions they want and also can tell them about terrible experiences they've had at the doctor's office. And talk about sort of ways that could look different and be different for them. So we try to make these, again, like really interactive, open to everyone. We've had anywhere between like 60 to, I would say, 130 people show up at them. So they've been pretty successful. We've gotten really good ideas from folks. Next slide. We also have a community navigator program. So I heard Dr. Thornton talking about the importance of sort of peer leadership, and that's what this is. So we work with folks that access services at our syringe access programs. We fund 3 agencies with mini grants to kind of recruit folks that are living with Hep C, have gone through Hep C treatment, that are in the process of trying to get treated for Hep C, to do some to do some training so that they in turn can work with their own peer groups around making sure folks know that they can get tested and they can get treated. So we have some of our like kind of quantitative outcomes here. Another thing that I'll just say is something that's a little harder to measure is part of what this work is doing, I think, is trying to change the culture of how people talk and think about hepatitis C in highly impacted communities. So our list had mentioned, the survey results about folks saying that, no one cares about Hep C, people just expect it's a thing that's going to happen if you use drugs and there's nothing to do about it. And so we're really trying to turn that on its head and just say, oh, hey, you can get that taken care of right now. Like we could go, we could get you into a low threshold program. And so I think that that's been really important and really meaningful. And we also try to make this super fun. So that's not just people are just like training all the time. We have like bowling parties, we've gone to the movies, like we try to just do fun social activities too. So it's not just like Hep C all the time. Next slide, please. We also have tried to get really creative about how people can tell their stories. So we did a short video series that if you go to endhepcsf.org, we have the videos up online. And so we have one that's explicitly, kind of solely focused on our community navigator program. We have one that's solely focused on people kind of telling their stories of getting cured. We also have a blog series on our website that's called Voices of NHEP-CSF, and we feature like our most recent blogs are of a heptologist in San Francisco that's talking about her low threshold Hep C treatment program and how they've adjusted in COVID-19 and how like GLIDE, one of our community-based organizations, is shifting their rapid testing model in COVID-19. And we have, this is Richard here, who's very open about his history with hepatitis C and substance use, that's gotten really involved in NHEP-C, and it's been an amazing volunteer and kind of activist in the community. And so we want to, in the sort of spirit of collective impact, just kind of highlight all of these voices and all of the work that we're doing from, wherever we're coming from, as all sort of equally essential and important. And you can see here that's one of the stills from the video from Community Leads the Way about our Community Navigator program. And we had kind of like a cool launch of the videos, and we had a panel of the community navigators that were featured in the program and did a Q&A. And we're just always trying to think of creative ways to kind of bring folks together to talk about their journeys with Hep C. Next slide, please. And this is just a quick kind of switching to data, like evaluation point for us. So we looked at the National HIV Behavioral Surveillance study that happens in San Francisco every 3 years, focusing on folks that inject drugs, and tries to recruit 500 folks that inject drugs. And so we asked people about Hep C treatment in 2015 and then again in 2018. And so just the point I want to highlight there is that in 2015, about 15% of people who inject drugs had been treated. And then 2018, 41% of people who injected drugs had been treated. These are also mostly homeless folks, about 70% of people. So that for us is like, okay, we're moving in the right direction. That's promising data. We've almost tripled our treatment access for folks that inject drugs, and it's insufficient, right? So we have to keep pushing and doing better. We have some different kind of low threshold treatment models that specifically target folks that use drugs. Some of them are co-located with our syringe access programs that are helping us do this work. I think that's it. Next slide. Oh yeah, sorry. So just some quick lessons learned, I think, about us and our community leadership work. So I think, you know, do what you can with what you have. Be willing to adjust and change course. Don't give up on big systems changes. So I know that like syringe access, I think, isn't legal in Arizona right now. So that's going to be a big systems change to change that to do some Hep C prevention. But I think don't give up. It takes a long time, but you can get there. And for us, I think leadership development has been really important, and understanding that Hep C leadership comes in many forms. So we like send our doctor folks out to talk to the other doctors, you know, and we send our community members out to talk to other community members. And they all have something to kind of add and to bring to the table. I already talked about like multiple thresholds for participation. So don't kind of confine all the opportunities to just attending a meeting. And prioritizing the inclusion of people that are most impacted by hepatitis C, and get a little creative about how to do that. And then keep asking how you can be doing better. Okay, that's it for me. Thanks so much.
Thanks, Katie. I appreciate your input. We're going to go straight to questions. So if anybody has any questions for any of the panelists, if you want to put those in the chat box, we will make sure that they're given an opportunity to answer those. I think I'll start out. I have a few questions that we got beforehand. And one question was, is there any evidence that the sobriety requirement is medically necessary for hepatitis C treatment? So again, there are restrictions, pre-authorization restrictions for sobriety requirement in Arizona. And yeah, the questioner was wondering if there's if that's medically necessary.
No, it's not. I'll defer to Carla though.
Yeah, go ahead, Michael. Did you have something to?
Well, I was just going to say, no, I mean, there are now reams of data showing that people who use drugs respond equally well if they're given a proper support system. So, but Carla can speak as a clinician.
Yeah, no, I completely agree with that. You know, one of the sort of criteria personally that I use is if someone is willing and able to take the medications. I mean, if somebody is unable to function, basically, then giving them hepatitis C medication doesn't make sense at that point in their lives. But if someone is doing well and they're even if they're continuing to use, obviously, if they're able to take the medicines and stick to the plan, then there's no evidence that is a dangerous or wrong approach.
I'll just add, if it's okay, that I mean, we have tons now of like real world experience in San Francisco treating folks that use drugs and treating them successfully. And I think something that I've heard a lot, both from clinical providers and from sort of our navigators on the front lines, is that like it's actually really hard to predict who's going to do well and who's not with treatment, and that there's many instances where folks have treated people and been like, I hope it goes okay, and then it's been totally fine. And then there's been times when folks assumed that patients would be fine, and they kind of got tripped up. And so we don't know. So everyone should have a chance. It's kind of how I think about it.
Thanks. All right, we have another question. None in the inbox yet?
Yeah, so I have a few that are in the question box right now. So just a reminder to folks, there's both a question box and also a chat box, and we'll take any kind of question from any kind of place. So there is, a lot of folks who are logging on and congratulating this panel, saying it's a really great presentation. And yes, I think there is intention to share these materials, and a recording of this will be made available through Chris and the, free AZ effort. So there is a question about, again, HCV treatment and sobriety restrictions, and any thoughts that the panel has about the best ways to, on an advocacy level, go about getting that barrier removed. Any suggestions, I guess, from the panel. And sort of related is another question that feels about sort of advocacy. Are there any plans to pursue a lawsuit against AHCCCS, which I'm going to assume is a correctional system?
It's actually Access, and that is the Healthcare Cost Containment system
okay.
that oversees Medicaid in Arizona.
Okay, so is there any plans to pursue a lawsuit against those folks for denial of claims? This was one part of the process in California, correct? So some general advocacy questions.
I can talk a little bit about the process in California because we had some restrictions that have all since been removed, and it happened in like a kind of multi-phase process. But I think there was a threat of a lawsuit. I know there was a more like lawsuits have worked in a lot of other states to kind of move things along more quickly. I think other things in California that worked is we had kind of someone on the inside at the state health department that was kind of really pushing our state Medi-Cal office around, you know, sharing lots of the articles about how the restrictions aren't necessary, and so having that kind of like state to state department conversations really helped move things along. We also had a pretty active advocacy group in California that had worked on it at the state level. And I think the other thing that was a really compelling argument is they had removed a lot of the restrictions, but not all of them. And it didn't really increase treatment that much. So I think the reason for the restrictions is their cost containment measures, and there's a fear that like everyone's going to try to get treated for Hep C at once and it's going to bankrupt like the Medicaid system. And that did not come to pass when they really, really loosened up the restrictions. And so, and I don't think it even changed that much without when they totally liberated all of the restrictions. And so I think you know, just pointing out those experiences of like that's not really how it goes down in reality. And for us to know that our, you know, folks that implement programs, that having sort of unfettered access in terms of Medicaid policy is insufficient, and that you need to do capacity building around treatment with programs like Project ECHO and other programs that help like ensure that providers actually know how to treat and are familiar with all the guidelines.
And for those interested, Southwest Recovery Alliance has put together a request letter for access to remove those restrictions. We've had it signed by multiple providers, other stakeholders. We've met with the chief medical officer, and we've offered all of the evidence that shows that those restrictions are not only unnecessary, but unethical and possibly illegal. So we have done a lot of work, and if you're interested in helping with having those restrictions removed, I'll get some contact information at the end of the webinar.
And I'll just add that the litigation is one of the most effective ways of getting restrictions removed. In Washington State, we were the first state that did that. The sobriety and specialist requirements had mostly been removed, but the fibrosis was still intact. And about 4 years ago, a federal court judge ruled that our Medicaid was in violation of the Medicaid Act and opened up access to all patients on Medicaid in Washington State. What it takes, though, is a plaintiff, and that is sometimes difficult. So if you have a patient on Medicaid who has been denied, feel free to contact me. At NVHR, we work with the group, the Center for Health Law and Policy Innovation at Harvard Law, and they have a team of litigators who has brought suit in both the Medicaid and correctional setting, and they have a pretty good track record. So happy to connect you as well.
And that is just about all the time we have for questions in the interest of.
Laura's got something.
You got something, Laura?
Well, okay, so two really quick ones. So there's a lot of interest about being connected with the Arizona ECHO team, and so I'm just going to assume that Carla, maybe you can be in touch with some of the folks on this panel to help make those connections. And then one question that I think is really great is there a standing order for naloxone here in Arizona where patients can go to the pharmacy and access Narcan without seeing a physician? And also a notice that the VA program here has a pharmacist-led has been very successful in treating Hep C. So the question is there an opportunity for a statewide standing order for MAVRIT or some other sort of Hep C treatment so that treatment naive patients can be given a prescription without seeing a physician?
So quickly, there is a standing order for naloxone. Anybody can go into a pharmacy in Arizona and get naloxone. We actually asked everybody that's watching this, go do that, and you can remove some of the stigma and discrimination that can unfortunately happen when people go to try to get it themselves. So if people want to go out and put that to the test and try to get naloxone, you can use your insurance for it usually. As far as a standing order for hepatitis C treatment, I believe that that is a bit too complicated for people just to go into the pharmacy and get the medication, whereas naloxone is incredibly safe and years and years and years of evidence that it's effective. The medications right now, there are too many possible side effects, not side effects from the medication. I'll let Dr. Thornton answer the question, but basically it's too complicated to just walk in and get it as though it were aspirin.
Yeah, no, thank you, Chris. I agree. I mean, it's, you know, the treatment has become much easier and much simpler, and it's nothing like it used to be, but it's very important, the level of liver disease that a person has before they actually receive treatment, that's to understand that. And that's why presenting them to Dr. Manch's and Ann Moore's echo would be awesome. And I think, Arlise, that you have Dr. Manch's information and we can get it out to the whole group. I think we can share his email, he said.
Great. Okay, and that brings us to the end of our webinar. I want to let everybody know we're going to do another webinar, and our next webinar will be all local people talking about hepatitis C elimination in Arizona. We just wanted to get a broad view of what's going on across the country, and so stay tuned. We will slowly be putting that together and get information out about that. So I just want to thank everybody again who attended the webinar. I want to thank all of our amazing panelists and all of those that are going to join with us as we move forward and take hepatitis-free AZ from kind of a dream and in planning stages to a reality, which is absolutely possible. Please find the Southwest Recovery Alliance on Facebook, and you can visit our website to keep updated on what our next events will be. And we look forward to future collaborations, not only with our panelists, but with everybody on the webinar right now. And we hope that if we can ever be helpful, that you reach out. And until then, we want to just end on a positive note that we can go out and maybe kick up the love a notch, particularly for people who are using drugs and who are living with hepatitis C, and move forward to see a hep-free AZ. Thanks so much for attending.
Thanks,
Thank
everyone.
you.
Thanks, Chris.
All right. Goes so fast.
I know it. Thanks you guys for inviting me. Thanks, Chris.
Carla, thank you so much.
Yeah,
I
thank you,
can't wait till
everybody.
COVID's over so I can come visit you.
I know.
I keep thinking about that. I was like, oh, she was so nice to like invite me back, and I wanted